So, welcome to Cambridge Forum, discussing May Doctors Help You Die. I'm Pat Zerke, Director of Cambridge Forum, and I'll be your moderator tonight. In November 2012, Massachusetts voters decide whether physicians may provide a dying patient whose suffering has become unbearable with medication to bring about an earlier death. The proposed Death with Dignity Act is almost identical to the Oregon law that has been in effect for almost 15 years. The Massachusetts Medical Society opposed this legislation, but their decision was not unanimous. Our speaker, Dr. Marcia Angell, explores the case for the Death with Dignity Act. How does the Hippocratic Oath square with the notion that a doctor might help a patient end his or her life? Under what circumstances would this be an ethical act for a physician? What are the risks of enacting death with dignity legislation? What safeguards against those risks does the act include? Whose interests does such a law serve? Marcia Angell is a senior lecturer in social medicine, specifically in the Division of Medical Ethics at Harvard Medical School. She is the former editor-in-chief of the New England Journal of Medicine. Trained in both internal medicine and anatomic pathology, she is a board-certified pathologist. She's also a member of the Association of American Physicians, the Institute of Medicine of the National Academy of Sciences, and has been elected a Fellow of the American Association for the Advancement of Science, among other honors. In 1997, Time magazine named Marcia Angell one of the 25 most influential Americans. Dr. Angell writes frequently in professional journals and the popular media on a wide range of topics, particularly medical ethics, health policy, the nature of medical evidence, the interface of medicine and the law, care at the end of life, and the relations between industry and academic medicine. Her 1996 book, Science on Trial, The Clash of Medical Evidence and the Law in the Breast Implant Case, was widely acclaimed, and she followed it in 2004 with The Truth About the Drug Companies, How They Deceive Us and What to Do About It, published by Random House. Most recently, she has written for the Boston Globe and the New York Times Review of Books about the issue of physician-assisted dying, the topic of our discussion. Welcome to Cambridge Forum, Dr. Marcia Angell.
Thank you very much, Pat, and I'm delighted to see you all here tonight, given the rain and the fact that it is the night of the first presidential debate. So I feel very pleased that you were willing to come out. On November 6th, in addition to weighing in on the crucial political contests, Massachusetts voters will decide whether physicians may provide a terminally ill patient with medication to bring about an earlier, more peaceful death if and only if the patient chooses. On the ballot will be a Death with Dignity Act that's virtually identical to the law that's been in effect in Oregon for nearly 15 years and in Washington State for 4. It'll appear as question number 2 on the ballot, and if it passes, it will be binding. It will become law in Massachusetts. Montana also permits this form of assisted dying through a 2009 decision by its Supreme Court, not a voter referendum, as in Oregon and Washington. The purpose of the Death with Dignity Act is to give dying patients who find their suffering no longer bearable the option of hastening an inevitable death. Good palliative care can provide adequate relief for the great majority of dying patients, but not all. Pain can usually be eased, but other symptoms are often harder to deal with. Weakness, loss of control of bodily functions, breathlessness, nausea. And the drugs to treat symptoms often produce unacceptable side effects. Even worse, for many dying patients is the existential suffering. They know their condition will worsen day by day until their deaths, that no matter how bad it is today, tomorrow it's likely to be worse, that their course is inexorably downhill, and they find it simply meaningless to keep soldiering on. Since they're generally not receiving life-sustaining treatment that could be stopped in order to bring about an earlier death, like mechanical ventilation or dialysis, since they're not usually on such treatment, they need another way to escape their misery. Like the Oregon and Washington laws, the Massachusetts Act contains a host of safeguards to prevent abuse. First, it applies only to adults who are able to make their own decisions. It cannot be used through advance directives or living wills, nor by people with limited decision-making capacity, such as patients with Alzheimer's disease. Second, the patient must have a terminal illness with a life expectancy of no more than 6 months as determined by at least 2 physicians. In addition, the patient must make 2 oral requests for medication to hasten death, separated by at least 15 days, and 1 written request with 2 witnesses, one of whom must not be related to the patient anyway, nor can that person benefit from the patient's death. By definition, the patient must be capable of swallowing the medication, usually barbiturates dissolved in a full glass of liquid, which helps to ensure that it's a voluntary act. The law does not permit euthanasia. That is, the injection of a lethal medication by a physician or anyone else. It does not permit euthanasia. And more about that later. If a physician believes a psychiatric condition is impairing the patient's judgment, the patient must be referred to a psychiatrist or other licensed counselor. No physician is required to participate in assisted dying. They may refuse for any reason whatsoever. This is a choice, not a requirement, for both patients and doctors. Now, a word about terminology. You'll notice that I use the term assisted dying instead of the older term assisted suicide. I do that to distinguish it from the usual suicide in which someone with a normal life expectancy chooses death over life. Unfortunately, terminally ill patients don't have that choice. They are facing imminent death and would simply be choosing the exact timing and manner of death. How has the Death with Dignity law worked in Oregon? The state health authority's Division of Public Health keeps detailed records of how and why the law is used, which it releases every year. You can find them in very readable form in the Oregon Division of Public Health website, both year by year and cumulatively. And I would recommend, if you're interested, that you look at this website. Just Google it. Oregon Division of Public Health. The law has now been in effect for nearly 15 years, as I said, and it seems to have worked pretty much exactly as intended. As of the end of 2011, it had been used to hasten death by 596 patients, accounting for only 1 in 500, or 0.2% of deaths in Oregon in the most recent year. Over 80% of patients had disseminated cancer. Most of the rest, the less than 20%, had end-stage emphysema or late amyotrophic lateral sclerosis, known as Lou Gehrig's disease. Nearly all were receiving hospice care, but found it no longer sufficient to relieve their suffering. The main reasons the patients gave for wanting to hasten their death was, in order, first 3, loss of autonomy, 2, the inability to engage in enjoyable activities of life, and 3, loss of dignity. Although pain was given as a reason by about a fifth of patients, it was near the bottom of the list. Of great importance, about a third of all patients who were prescribed the medication didn't take it, but kept it at hand just in case, because it provided peace of mind. There has been no evidence of abuse, either in the state records or in the careful research carried out by investigators at the Oregon Health Sciences University. Though there has been an increase in the incidence of assisted dying over the years, from 16 deaths in 1998 to 71 in 2011, that was to be expected as people became more familiar with the law and efforts by the Bush administration to intimidate Oregon doctors were stopped. The law is still used sparingly, and the point of it, after all, was to make assisted dying available, not to make it unavailable. At first, there were fears that the availability of physician-assisted dying might crowd out good palliative care, but it has had the opposite effect. Most experts believe that Oregon now has among the best palliative care in the country. There were also concerns that the law would be used disproportionately by disadvantaged patients, for example, by the poor or the uninsured. But in fact, the patients who died in Oregon were relatively affluent and well-educated, and almost all had health insurance. Far from being especially vulnerable, they were the type of people who particularly value control and independence, qualities that they had exercised when they were healthy and didn't intend to forfeit just because they were dying. There has been no indication of coercion by unscrupulous family members. In short, observers looking for a slide down a moral slippery slope have not found it. Probably no law works absolutely perfectly, but this one seems to come about as close as possible, and it's now overwhelmingly supported by the public in Oregon and, according to one study, by most physicians in Oregon. The experience in Washington, although shorter, is much the same. Whether patients who requested assisted dying did so because they were depressed is more difficult to evaluate. The symptoms of depression overlap almost entirely with those of terminal illness, and dying inevitably produces sadness. So far, the limited evidence is that depression is no more frequent in the patients who request assisted dying than in other terminally ill patients. In fact, a recent study showed that the patients who obtained the medication were less depressed and anxious than those who didn't. In a sense, the law can be seen as a sort of treatment for depression in dying patients because of the peace of mind and sense of control it engenders. When they got the medication, they became less depressed and anxious. Unfortunately, there have been no good studies of other treatments for depression in this setting, so we really don't know whether they would work or not. Nevertheless, the Death with Dignity laws, including the ballot initiative in Massachusetts, require physicians to refer patients for counseling if they believe a patient's judgment is impaired by depression or another psychiatric condition. And that was a common reason Oregon doctors gave for denying requests for assisted dying. But depression alone does not make a patient ineligible for assisted dying. It must be severe enough to impair judgment. And that seems to me to be exactly right because of the inevitability of some depression in this context as judged by the standard diagnostic criteria. Nearly everyone knows someone who has died a protracted, difficult death, some of whom plead for a faster death. That real-world experience is reflected in the polls in Massachusetts. In a recent Suffolk University NBC poll of 600 likely Massachusetts voters, 64% said they supported the Death with Dignity Act. 64%, it's a big majority, while only 27% opposed it. Nevertheless, there's strong opposition from several organizations who are trying to convince voters that the law is dangerous and they should rethink their initial support for it. These organizations include the Catholic Church, the Massachusetts Medical Society, and a collection of disability groups. So I'll discuss them one by one. The Catholic Church, of course, opposes assisted dying as a matter of religious doctrine, which they have a right to espouse. However, as we know in the case of artificial birth control, Catholics don't always follow the teachings of their church hierarchy. And I suspect that will be the case here. The Massachusetts Medical Society, after heated debate in their House of Delegates, decided to oppose the law because, in the words of the president at that time, the president of the Massachusetts Medical Society, assisted dying is, quote, incompatible with the physician's role as healer, close quotes. But this isn't about physicians or a one-size-fits-all concept of their role. It's about patients, specifically patients for whom healing is no longer possible. And when healing is no longer possible, then physicians should instead concentrate on relieving suffering in accord with the patient's needs and wishes. There have been no polls of physicians in Massachusetts, but I suspect that many would disagree with their hierarchy just as many Catholics do with theirs, and see their role as being compassionate and responsive to the specific circumstances of each patient. The leadership of the Massachusetts Medical Society also makes much of the fact that doctors cannot precisely predict life expectancy for any given patient, and that's true, since life expectancy has to do with statistical probability. Some patients with a life expectancy of 6 months will die at 5 months, some at 7 months. But doctors can know with great certainty whether a patient has a terminal disease, such as metastatic cancer or Lou Gehrig's disease. And there was little doubt about that in the Oregon cases. Remember, nearly all of them were on hospice. The important point is that these are patients who are suffering from a fatal disease that will end their lives in a matter of months. It's the suffering that matters. The possibility that it might go on even longer than anticipated would be no comfort at all to these patients. It's the suffering they want to stop. Now, there are, of course, anecdotes about patients who were told that they had metastatic cancer and went on to live happily for 20 years. But these are akin to urban legends. They tend to be undocumented stories that have a long life because they're often used to give hope to patients who are given a dire diagnosis. Moreover, it's unlikely that such patients, if they exist, would request assisted dying. As for the disability groups, I agree that the issue of how disabled people are treated in society is very important. But that's an entirely different issue from assisted dying. This law concerns terminally ill patients, not disabled people. It has nothing to do with disabled people. Disabled people would simply be ineligible for assisted dying. Like other Massachusetts voters, of course, they will have many points of view on question number 2. But as a group, they have no special standing since the law affects them no more than it does anyone else. In conclusion, I'd like to reiterate a few key points since there will be a lot of misleading hyperbole in the next month. First, this is not a debate about life versus death. All of the patients will be close to death. The debate is about the manner of death. Second, the Act does not require physicians to provide medication to patients who request it if they don't wish to do so. It simply provides one more choice for both physicians and patients as they deal with terminal illness. In the great majority of cases, both physicians and patients find palliative care sufficient. Assisted dying would be reserved for those cases in which both physician and patient agree that it's not. Third, the availability of assisted dying does not replace palliative care, as we have seen in Oregon. Assisted dying and palliative care are no more mutually exclusive than are the medical treatment of heart failure and heart transplantation. One is used when the other fails. At base, I believe arguments against the Death with Dignity Act stem from the paternalistic notion that terminally ill patients can't be trusted to know what they want, that they need to be protected from themselves. That's wrong. And I believe it's actually a little bullying. There's something of the bully in all of this. Patients and no one else are the ones to say when their suffering has become unbearable. An individual physician should be able to stand with them without fear of retribution. Why should anyone, the state, the medical profession, anyone, presume to tell someone else how much suffering they must endure as their life is ending? So I hope you'll vote yes on question number 2. It really is the right thing to do. Thank you.
You're joining us at Cambridge Forum listening to Dr. Marcia Angell discussing the question, may doctors help you die? So as moderator, I want to ask a small question and then maybe a bigger question. In the studies in Oregon, is there a record of how many times doctors refused a patient's request?
There has been, it's not a part of the records, no. There has been a study of that, but it's fairly old now. I think it was published in 2000, and maybe the data were from 1999. About 80% of requests were refused.
And you said one of the reasons was because of depression. Were there other reasons that were identifiable?
Mixture. Some they didn't feel that that's what doctors should be doing. They were ethically opposed to it. Some they were worried because the Bush administration was threatening doctors, saying that this was a violation of the Controlled Substance Act and they might have their license taken away. That went to the Supreme Court, and in 2006, the Supreme Court sided with Oregon, and so that freed doctors from that fear. Some may not have wanted to take the time, just a variety of reasons. But I believe that about 20% said that they thought that the patient was depressed.
And then my bigger question, could you summarize whose interests does this law serve? Who does it benefit?
Suffering patients and everyone who loves them.
Primarily patients.
Of course.
Does it also benefit physicians?
No.
Those who might fear retribution for helping a patient to die more quickly?
I see what you're saying. Of course. Because in many states it's illegal. It is not illegal in Massachusetts. It's just that physicians worry because they could be prosecuted even if it's not successful. Other states, they do have laws against it. And so when physicians do help their patients to die, which they do in every state, they can legitimately have some concern about this. And so what you get then is is a situation in which it is not the patient's needs and wishes that govern what happens, but the physician's courage and compassion. The focus then becomes on the physician. Is he willing to do this? And it really ought to be on the patient. And so the law does protect not only the physicians, but the patients too. It becomes their wish instead of what the physician decides to do.
This move seems to be spreading slowly,
Yes.
perhaps. Could you talk a little bit about the role of Dr. Jack Kevorkian in the whole notion of physician-assisted dying?
Yeah. Well, of course, Jack Kevorkian was not the poster child.
God.
He wasn't the poster child for this. Patients didn't have to be terminally ill. He went all around the country. He did it fairly indiscriminately. He had no expertise in many of the conditions that the patients were said to have. He didn't call in other specialists. This was a solo enterprise of his. Nevertheless, it's remarkable that he came to, that Michigan, his state, passed a law specifically to stop him. And he went to court, I believe it was 3 times, and the jury refused to convict him. There was remarkable sympathy for him in the public. And it wasn't until he actually committed euthanasia on television. This was not assisted suicide. He killed someone on television, that he was convicted of second-degree murder and went to prison. So there was a great reluctance to prosecute him.
So his legacy is somewhat mixed in that it seems like he brought this issue into the public conversation.
Yes, in some sense. I've written about this subject in the October 11th New York Review of Books, going through the history of the right to die movement, not just assisted dying, but going back to Karen Ann Quinlan. In those days, you couldn't remove a ventilator or life-sustaining treatment until her case, and what has happened since then. And I talked about Jack Kevorkian, and I referred to him as the bad cop in a bad cop, good cop sort of scenario, because then there was a physician named Timothy Quill who helped a longstanding patient of his to die, wrote about it very candidly in the New England Journal of Medicine. The attorney in his county, this was in Rochester, New York, brought him before a grand jury for manslaughter, and the grand jury refused to convict him. And he, in my judgment, did everything right. Very courageous. He then sued New York State to overturn the law, and that case went to the Supreme Court. And since then, he brought it out of the shadows, and he's been a very important spokesperson. So in my article, I referred to Kevorkian and Quill as the bad cop, good cop.
So we should all be looking for the New York Review of Books.
It's out.
It's online.
They date it very far ahead.
It's online. So you're joining us at Cambridge Forum as we continue our discussion with Dr. Marcia Angell of the Division of Medical Ethics at Harvard Medical School, exploring the question, may doctors help you die? At this point in the program, we'll take questions from the audience, so please come to the microphone in the center aisle and ask one question, one succinct question.
A question I thought you were about to ask, but you actually asked the opposite. I'd like to ask who benefits from the situation as it is. I mean, obviously there's inertia in social attitudes and there's inertia in people's comfort with this idea, but are there people or groups that actually benefit from a law that forbids?
I think so. I really don't think so. A lot of my work throughout my professional career has dealt with people who have financial interests in one thing or another, in the prescription of drugs, for example, or in our healthcare system, a market-based healthcare system. I don't see that here. I think it's a traditional belief by some of the groups that I mentioned, and you know, the necessity for this is really fairly new. Before Quinlan, for example, it was technologically impossible to keep someone alive for very long. And now, particularly with antibiotics, people used to call pneumonia the old man's friend, and it was also the terminally ill person's friend. You can treat that now. You can do a lot of things that you didn't used to be able to do. So I think the attention on the right to die is fairly recent, the last 40 years maybe, and the move from the right to die in the sense of withholding life-sustaining treatment, which includes any treatment now, feeding tubes, ventilators, dialysis, antibiotics, you can withhold any of this at the request of a patient or the patient's proxy. That then began to lead to the effort to help people who were on no such life-sustaining treatment. An example that I sometimes give is if you have disseminated lung cancer, you might need to be on a ventilator in order to survive. If you have metastatic cancer of the pancreas, you can be suffering just as much, but not be on a ventilator. So then what do you do? So in a sense, this was an effort to deal with people who didn't have life-sustaining treatment to withdraw. And in fact, one of the cases that reached the Supreme Court on this in 1997 actually pointed to the 14th Amendment equal protection of the laws and said everybody ought to have equal protection of the laws.
Just your comment on something, and that is, I don't know how, hospital administrators have sort of weighed in on this, but if you look at their position, one of the things they're concerned about is simply the financial health of their institutions, and a lot of them have perennial difficulties. But from a hospital administrator's point of view, the fact of the matter is when you keep people alive beyond, a humane ending, as we're discussing here, there actually is something of a profit motive to do that. Now, that's kind of a cruel thing to say, but there is an incentive among hospital administrators not to do things that really reduce, the financial viability of their institutions. It's just the way it is.
It seldom comes to that point, because one of the things that dying patients fear is ending up in the hospital and dying a medicalized death with tubes and the unpleasantness of being in a hospital. And the assisted dying law allows patients to die where they want to die, which is at home. In Oregon, I think it was 96% died at home. I think only one of the 596 patients who've used that law has died in the hospital. They die at home, and this law helps them to do that. So the administrator never has a chance to weigh in.
Okay, that's a good answer.
That's pretty much answered my question. I was concerned how it was going to be managed, because I have heard that in Switzerland, there is a euthanasia clinic, but you're segregated in a cell without your family, and that seems really very tragic. So I wondered how flexible they were going to be, whether you needed to die in a hospital, whether you could have your family around. What was the situation?
In Oregon, they die at home, but let me correct you, euthanasia is illegal in Switzerland. It's assisted dying. They can do assisted dying in Switzerland. I know of no isolation. In fact, I've seen a movie of it.
That there was money taken and families weren't allowed, and they were
No, I've seen a documentary
Oh, good.
where
I'm glad to
families
hear
were
that.
allowed. Yes, yes.
I'm sorry, can you clarify that? Because you spoke, I was trying to listen to your answer. You said it was a documentary?
Yes, there was a documentary of someone who went to Switzerland to die. It's assisted dying. It is not euthanasia. And the family was there.
So it wasn't what you were
No, no.
You mentioned that in Oregon, almost all of the patients die at home. Does that mean physicians are going to the home to observe the patient and visiting the home often? When are all these precautions that are stated in the proposed Massachusetts law require a lot of attention by the physicians?
Yes, but
Where
that's
will they
before
be?
they actually take the medication. So in order to qualify to get the medication, they have to go through all of these safeguards. They have to make sure that it's voluntary, that they
Which would be
qualify.
done in the hospital.
No, it would be done in the physician's office or at home if the physician comes to their home. It would not necessarily be done in the hospital at all, and probably it's not. I'm not sure about that. But once they get the medication, then they take it when they want. And as I said, a third of them never take it. They die of the underlying disease and just have it for the peace of mind that it provides.
Okay, thank you.
Could I ask you to say a little bit more about the process? How do patients in Oregon find out about this option and find out about the process, the 2 requests orally and the 15-day waiting period, the written request and the kind of witnesses?
Yeah.
I mean, is it posted on the wall like monthly breast exam protocols?
Well, you know, it's now very much a part of medical care in Oregon, even though it isn't used very much. Everyone in Oregon, or almost everyone in Oregon, knows about it and knows of someone who considered it or did use it or got the medication. I've talked to several people out there, and they say nobody even thinks about it anymore. It's just one part of medical care, of good medical care. The last poll I saw, and that was a few years ago, 77% of the public favored it, and almost all knew about it. So it's very...
How would this information be disseminated in Massachusetts if the ballot initiative passes?
I suspect in much the same way, word of mouth. I don't think it would be used very often at first. Until doctors got used to it, patients and their families got used to it, and gradually it would permeate Massachusetts consciousness and the awareness of the medical profession.
I think, Doctor, you'd agree with me that only a small fraction of deaths where the prescription's taken, the doctor is present in Oregon and Washington.
In recent years, that's correct.
All right. And,
At first, doctors tended to
right.
be there.
and I think you'd agree with me, as I think you said, that in over 90, 95, 96% of the deaths take place at home or in some small percentage at the end of hospice, correct?
Mm-hmm.
Now, do you think it's generally known that patients who get this prescription who do not take it at the hospital, like Mass General Hospital, go to the local CVS to get the prescription filled? Do you believe that's generally known in the debate this year over this ballot question?
Excuse me, would you run that by me?
Do you believe it is generally known that the actual prescription for the lethal dose is not filled at the Mass General pharmacy on the first floor, but is filled at your local pharmacy?
Oh, I don't know.
All right. But is that pretty much what is contemplated under
I
the
don't know.
statute?
I don't remember that part of the statute. What would be your
Well, my point is
Is-
that I think that people think it's done at Mass General, when in fact it's actually done at your local CVS. That's where you get the prescription, or you send your child to get the
And the
prescription.
relevance of that?
And the relevance of that is whether or not there is this medical umbrella that you talk about, this lack of any abuse or due process. Because I was intrigued with the notion of Oregon, as I recently went to read the Oregon material, and this is what I found. In the whatever amount of years, it's 15, 16, I can't remember, you probably know,
Almost 50.
less than 5% of the people that died were referred by either the attending physician, that is the thoracic surgeon type doctor, or another consulting physician, another thoracic surgeon type doctor, referring people to a psychiatric evaluation. And in last year, what was struck me last year was of the 71 people, I think it was 70 or 71, and you mentioned earlier, one had been referred to a psychiatric evaluation. Now, the point of this, and I'm about to ask my question, but the point of this is, and I know by your nodding you are somewhat familiar with what I've been reading, but the point of this is that, I mean, a lot of psychiatrists have raised questions about this low number in Seattle. And they've raised questions about it because when they look at the Mass General end-of-life program on the cancer ward, they've got 70, 80% of the people are in on cancer, and over 80% of them are on antidepressants. So at the point at which they're about to have a conversation on hasten my death, please give me the lethal prescription, they are already on antidepressants. And so there's been, I know you're familiar with it, there's been a lot of medical turmoil, isn't the right word, it's not genteel enough, but there's a lot of medical turmoil over the fact that this movement is not putting in place a system which can adequately care with depression, not unhappiness. We're talking about clinical depression. We're talking about Gonzani stuff. We're talking about William Breiber stuff from Sloan Kettering. We're talking about something that's clinically depressed. So my question to you is that my sense is that if you look at Oregon and you're dealing with a population that's supposed to be 50% depressed and Oregon says it's 4% depressed, should we be alarmed about relying on Oregon?
No, you should not be alarmed. Let me answer that, first of all, by saying that physicians do not have to agree to provide assisted dying, and in many cases, they don't because they believe, and there are two of them, that the patient is depressed. The 71 who died last year, I have no information that they were on antidepressants and anywhere near what you're quoting for the oncology ward at the Mass General Hospital. I don't know that any of them were. But the rule is that if they found that it impaired their judgment, any mental condition, they had to be referred, and that's the one patient that you're referring to. If you go to the DSM and you look at the criteria for major depression, every one of them will apply to a terminally ill patient as well as to a depressed patient. Things such as difficulty sleeping, rumination about death, loss of weight, loss of appetite, all of those things, there are 9 criteria apply to terminally ill patients. So that I don't care how expert the psychiatrist is, he or she cannot tell that this is a clinical depression as opposed to terminal illness. Only when it becomes clear that the patient's judgment is impaired, that the patient doesn't understand the nature of the decision or the likely consequences, must that patient be referred. And even then, the psychiatrist cannot say, oh, yes, you were clinically depressed. The other thing you should know is that there has...
They don't get to the psychiatrist.
If their judgment is impaired.
But in Oregon, doctor, they don't get to the psychiatrist.
They are referred if their judgment...
A thoracic surgeon makes the judgment.
Yes, who then refers them to a psychiatrist. And you know, most cases of depression are treated by primary care doctors, not by psychiatrists. There was one other point I was going to make, but it slipped my mind. I'll come back to it. Okay.
I'd like to make a comment rather than a question. First, just a response to you as a primary care physician in practice for a long time. All the patients that I've seen who have died, I don't recall anybody who has been depressed to the degree of altering their ability to decide and make the judgment. It was not interfere with the judgment. Clearly, all the other things, as you say, apply. But the thing that I wanted to say is that physicians are bound to care for patients and try to alleviate suffering. Now, that is a broad term, what suffering is. Our focus up until Quinlan case was basically caring for the patient in the Rockwell idea of holding the patient's hand. The idea that once a person is terminally ill, we should then, up until the patient's terminally ill, we should now then change, it's inappropriate for us to change to comfort the patient. Well, that is basically alleviating suffering as well. So it's the physician's job is basically to guide a person through their illness wherever it's going to take them and not to abandon them at any time.
That's
So
right.
that it's a continuation of whether care of the treatment that we use, the medical treatment is no longer effective, then other ways of caring for the patient should continue. And basically, as a physician, you always have to allow some exit for the patient, because we have a way now of trapping patients within the medical system, because we have so many ways of continuing life, that if there isn't an exit, then there is no way for a patient to die. So this really supplements it and makes it, I think is clearly an appropriate thing to do.
I agree. Oh, the other thing I wanted to say about the psychiatric element is that the trials of therapy for depression usually take place in young people who have no other illness and are taking no other drugs. There has been no good controlled research study of antidepressants of any sort in this setting. We have no idea whether it would work or not. So
I take great deference. I'll be happy to send you tomorrow 2 or 3 of the most recent ones. I'll send them to your office.
It would
That's
be-
my view, actually.
It would be very helpful if you could come to the microphone to respond, because half of the
I
conversation
don't
is
like to go
being
to the
missed.
forums and talk so much, but as a lawyer, I suppose that's part of the problem. But the problem is that there are studies. There just are studies that talk about the cohort that has to deal with people who are in the various cancers. There just are studies of them. And whatever fine-tuning we make with respect to the DSM, the bottom line is there is a disconnect which is making a lot of psychiatrists uncomfortable. I've talked to probably 25, 35 in Massachusetts in the last 2 months, none of whom want to come out publicly. They're very concerned about this particular issue. And it's hard to articulate or make it interesting, but the fact of the matter is when you look at Oregon, you have to come to this conclusion. You got 2 options. Well, you have one option, it's accurate what they portray. 2 is the doctors aren't doing, a very good job. Or 3 is the average mental health condition of people suffering from cancer in Oregon is approximately 18 to 20% greater than any place else in America. That's what it is. You've seen Ganzani's study. You've seen her study saying
I
that
certainly have.
Oregon,
I
you have
certainly
seen
have
it.
read Linda Ganzini's
And they're worried.
studies, and
They're worried
no,
that it's
she is
not being picked
worried.
up. I have it right here. I have
She
it.
is the one who...
I can give it to you.
Wait a minute, now let her respond.
I'm quite familiar with the medical literature on the treatment of depression and the lack of medical literature on the treatment of depression in dying patients. I'm very familiar with Linda Ganzini's work. In fact, I've published her work. She is the one who said that depression was no more common in dying patients who receive medication than in other terminally ill patients. She is also the one who did the recent study in which she found that those who got the drugs were less depressed and anxious than those who didn't. I'm not going to stand here and read this. I know this study. And I think you're reading it a little bit, differently. So she would add to my view on this. And in fact, the British Columbia Supreme Court heard a case in which 3 plaintiffs were successful in overturning the Canadian law against assisted dying. And that's now been held until the other side can appeal to the federal court. She was a witness for the plaintiffs there. As was I, that's right. She believed that the law should be overturned.
I want to thank you for coming to speak tonight. My father in 2004 had esophageal cancer, so I think if this is done correctly, it looks like it's a good thing. I think my only fear is when you said that a patient gets the medication, they don't have to take it. So if they pass away at home, they still have a life-ending medication at home. So what happens to that medication?
I don't know. I know of no problem with it, but I don't know. Maybe they come and pick it up.
They don't.
I was understanding everything except the depression. So if I was depressed and then drugs worked and I felt that I was no longer depressed and making good decisions and rational decisions about my health, would this law not allow me to get the meds?
If you were depressed and took something for your depression lifted, but you still wanted to end your life sooner?
Yeah.
Sure. I mean, if you had qualified in every other way, sure.
But I heard that so even if 100% of the people are on meds and they're living a healthy life, even though they're clinically depressed,
yes, and in fact,
they can elect to
yes,
receive these drugs.
Yes, if they qualify.
Good.
And in fact, the self-same Linda Ganzini studied that. It wasn't a controlled study, but she looked at the patients who had received antidepressants and found that only 11% changed their minds. The others went ahead, just as you're suggesting.
So as you said, the Death with Dignity Act was heavily debated in the Massachusetts Medical Society. So I'm assuming that there are a good amount of doctors in the state that are in support of this act. I'm just wondering, is there a group or some sort of union that they've all come together in to kind of spread the word and support this?
No, I don't know that there is any such group. You're talking about a group of doctors who say yes. I don't know that I think probably not, or I probably would have heard. Yeah. In the debate, it was quite a heated debate, and I have heard, I wasn't there, I have heard that something on the order of 25% wanted to support the law. There may have been people who didn't want to take a stand at all, who wanted to remain neutral. Which is what the proponents of the law had hoped for. But the majority wanted to oppose it and did. And I wish there had been a poll of doctors in Massachusetts. It would be nice to know where they stand.
That's what I was wondering.
No, I don't know of any way to know that.
Thank you.
I am a public health provider and practitioner, and even though I dearly love our Commissioner of Public Health, I am very worried about the implementation of this should it pass within the Department of Public Health that is woefully under-resourced for just doing things like monitoring the state lab, which you've heard about, I'm sure, and the nursing home monitoring is far from complete. So what budget will be provided and resources for Department of Public Health to be able to implement this and to oversee it and monitor it?
I don't know the answer to that. I don't think it would be very expensive to monitor at all. This is really a fairly simple law. And you can lean over backwards and make it very intrusive if you want, but then it becomes a law that can't be used rather than a law that can be used. I see a minimal bureaucracy for this, just to keep the data, just to collect and keep the data.
I want to follow.
Any comment on that? In Oregon, they have no money to do the job they're asked to do. Each year, they've asked for more money. The state will not give them more money to do the job. Which is undoubtedly probably what's going to happen in Massachusetts, is my sense.
Which division is it in Oregon that actually
Division of
keeps
Public
the
Health.
statistics?
I think it's health.
So it is
health
public health.
Division of Public Health within the Health Department.
One of the reasons that they don't need a lot of money is because the movement towards assisted physician suicide provides a lot of data themselves, provides a lot of resources themselves to the state. And one of the things that you don't really get a sense about is that the movement, so-called movement, they interact with people on the web before they ever talk to their doctor about hastened death. So in Oregon, the statistics will show that 80 to 85% of the people that get involved with the request for hastened death have a volunteer that walks in with them, from, I forget the name of this group, but it's a pro-assisted suicide group. So it's kind of a situation where, although this looks like a state-neutral situation, and again, I'm just looking at the statistics from Oregon, and this group claims success in this area. They like to increase their percentage of helping people each year. And they're actually at 65% in the last 2 years at the deaths themselves. So a lot of people don't have a sense that this is not a neutral activity. But Oregon has no money. Pardon me? My question is, does anybody know if Oregon has money? Oregon has no money. And my question is, why should we back a bill where, in effect, a ballot question, in effect, where it is being supported by a group and groups which are taking people and driving them to the doctors, insisting upon a hastened death prescription, driving them to the pharmacies with respect to a hastened death prescription. I won't say any more, but you may think it's drastic, but this is, if you go on the website, you'll see this is exactly what happens in Oregon.
I think this is exactly the kind of scare story that you're going to be hearing over the next month. Not documented, it comes from nowhere, it's just simple fear-mongering.
I think if I were, say, 80 years old and had terminal cancer, I wouldn't be driving myself to the CVS. I'd be calling somebody to help me. I mean, just, you know, I think just to be realistic, I don't picture some shadow organization sort of gathering up vulnerable seniors and bringing them to the CVS to get their death pills. I mean, it's sort of, it reminds me, well, it just strikes me as kind of fear-mongering. I think that's the correct word. The point is that you should have the choice.
That's
and
right.
if you're elderly and if you're terminally ill, a friend of mine was not elderly, in fact, but had pancreatic cancer and died quite young. I mean, he suffered incredibly and had to suffer. And what this does is it frees a patient to make that request, and it frees a doctor to honor that commitment they've made to end the suffering, to help patients end suffering. If a doctor fears they're going to be brought up on manslaughter charges for helping an 82-year-old person who has terminal cancer, or a 45-year-old young man who has pancreatic cancer and has been suffering for months, if he or she fears being brought up on charges of manslaughter, that's an inhibitory effect on the free choice of the patient as well as the free action of the doctor. So I think we should look realistically at it, that if you reach a certain stage of life where you're painfully ill, where you are in serious pain, I mean, this question of depression, I mean, it strikes me that it's normal to be depressed if you're dying
Depressed
and you
people
know
have
you're
rights too,
dying.
don't they?
I mean, it's not an illness. If you're 25 and you say, I can't see the reason I'm living, that's depression. But if you're 82 and you have terminal cancer racking your body, of course you're sad and depressed. The question is, does that depression interfere with your ability to make a judgment about your own level of pain? And I think you can't take that autonomy away from a patient, and doctors shouldn't be prosecuted for accommodating the wishes of their patients on their deathbeds.
There's a disparity also between people's meddling with what these patients want for themselves, and the lack of such meddling if a similar patient refused dialysis or asked to have a ventilator removed. You could do that without all of this, these assumptions that that awful things will happen. And every day, people refuse life-sustaining treatment on the basis of their wishes, or often on their proxy's wishes. And there is no hint of widespread abuse whatsoever, even though it would be easier to abuse that, in the sense that if you're on a ventilator, you may not be conscious. It could happen without your even knowing it. And yet there is no indication of abuse if people say, no, I want to stop the life-sustaining treatment. So why here are people so excited about abuse that good evidence shows hasn't occurred? any more than it has in the case of withholding life-sustaining treatment.
Why do you think they are so excited and exercised? Why was there such a debate?
I think there was a debate at first about withholding life-sustaining treatment. It took about 14 years after Quinlan until every state had a Natural Death Act that recognized living wills, and it was only in 1990, 14 years after Quinlan, that the U.S. that the U.S. Congress passed the Patient Self-Determination Act that said that every patient who was admitted to a hospital that receives federal funding, and that's nearly all of them, has a right to refuse any treatment for any reason whatsoever and can name a proxy to make decisions for them if they become incompetent. So that was 14 years from Quinlan. That was controversial too. Anything that's new is by definition almost controversial.
I wanted to add a point that the proxy who can make the decision to, say, withdraw some life-sustaining measure is often a child of the patient who will benefit financially from the death of the patient, and we allow that all the time.
Yeah, you have to.
I'm a lawyer who does that, and I think most of the children are really looking out for the best interests of the parent,
exactly.
But they are in a conflict of interest position.
That's what I was going to say. Any law has to be made on the assumption that most people behave the way most people behave, that most families are loving. You could always conjure up, a case of somebody coercing somebody to ask for medication, but this would be unusual, to say the least. And to try to formulate laws based on the assumption that this would be typical is poor lawmaking.
Jeanette.
I have a simplistic kind of thought about this. When the abortion issue was so great, nobody was forcing anybody to have an abortion. It was a woman's choice. And it seems to me that no one's forcing anybody in this room to take these pills. If I want to, then I have that choice. But you don't have to if you don't want to. And so I'd like to have the privilege to make that choice for myself.
Exactly.
I'd like to follow up on something the young man in back said when he talked about his father dying. How will this law affect families? You've talked about it as something between doctors and their patients, but clearly we've just said there should be a loving, we hope, family involved as well.
The law does suggest that patients choose to bring their family into this, but doesn't require it because these are grown-ups. And as far as I know, usually patients did have their families with them when they died in Oregon. But that's not required. And there have been studies, questionnaires of family members afterwards who said, yes, this was what he wanted. And this is what I wanted since this is what he wanted.
So the law benefits families as well?
Oh, yes. Oh, yeah. I mean, it must be awful to watch a loved one die by inches, particularly when they're asking, let me die sooner.
Where is the dignity, the death with dignity?
Where does that word come from?
Where is the dignity in this whole process?
Well, this is what the patient said in Oregon. That was their third reason for requesting it. And for many people, there is indignity. For example, when they have loss of control of their bodily functions, they have to be in diapers. They feel a loss of dignity. And as I said, the type of people who used it in Oregon, particularly in the early years, were people that would probably be very sensitive to indignity. These were well-educated, affluent people who who didn't want to endure this, to be seen that way by their family and others.
Well, the picture that was chosen for your New York Review of Books piece was the death of Socrates, which we picked up for our flyer. And there is something very dignified about that scene, as Socrates was not asking his physician to end his life, but he was doing what is envisioned in this act.
Well, I wasn't pleased about that choice of illustration because, as you said, he had to do that. This was his punishment. And what we're talking about with the Death with Dignity Act is not taking a perfectly healthy man with a normal life expectancy and saying, here, swallow some hemlock. So I thought that the illustration was unfortunate.
Was misleading?
Yeah.
Okay. So just to go back to that question, that you talked about the debate over withdrawing life support. Where do you feel that the resistance to this act lies? I mean, you talked about some of the organizations that resist. You talked about the fact that we generally don't like change and something new, but what is the source of concern or fear?
Yeah. I think there is a lot of misleading information about it, and it's often presented as your doctor may kill you, and it gets confused with euthanasia. But what we saw when this first came before some states in the 90s, in the early days, it came up on a ballot initiative in California, and then in Washington state, a different law from the one that later was passed. And the safeguards were not nearly as narrow as they are in Oregon and then were in Washington, and I hope will be in Massachusetts. So that in the initial attempts to do this, I think that maybe euthanasia was allowed, voluntary euthanasia. I don't remember the details, but it wasn't as narrow. Maybe you didn't have to be terminally ill. There are some countries, for example, in Switzerland, you do not have to be terminally ill. In the Netherlands and Luxembourg and Belgium, you do not have to be terminally ill. So originally, similar laws to these countries were presented to voters in California and Washington. And while the polls before the vote showed that people favored them, not overwhelmingly, as in Massachusetts now, but the voters favored them, they failed. And I think one reason is that when voters who instinctively wanted to be able to see suffering patients end their lives sooner. They got in there and they looked at the fine print and they thought, oops, this is about death, better not do anything. I think there is a sort of default position when you see a ballot initiative to say no. If you haven't read it completely and thought about it ahead of time, you say no. And so when Oregon decided to try it, they made it very narrow. These safeguards would leave out a lot of people who might want to use this law. People with early amyotrophic lateral sclerosis, people with early Alzheimer's, people with certain neurologic conditions that, terrible strokes that can leave them suffering for years, but they're not terminally ill. It was made narrow as the price for getting public support, and that worked. And with each year, the support in Oregon and Washington has gone up. But still, you look at the safeguards and you imagine somebody in Massachusetts who hasn't read the law, who hasn't thought about it, and who kind of thinks it's probably a good idea, but gets in there and sees all the fine print and says, wait a minute. And I think that if it fails, it will be for that reason. And that's why I think it's so important that those of us who favor the law go through it in detail, go through Oregon in detail. And I think there's one disability group called Second Thoughts or something like that, that speaks, it's a good name, it speaks to the fact that some people may believe it, support it, and then at the last minute have second thoughts. And I think the important thing to do now is to convince the public that your first thoughts were right, you were right the first time, and to have the courage of your conviction.
Just one question about, do you think that the medical society, by stating that this is not the role of a physician, will have a negative effect in terms of if the medical society were behind this, I would imagine that patients would begin to follow what their physicians are saying. Now we have the opposite, that physicians don't want to see a change in their role. Or
some physicians, the leadership.
Well, the majority of the physicians. didn't want to see
No, of the delegates.
Well, excuse me.
They're self-selected.
That's correct.
Yes.
Okay, but still.
Yes,
but
no, I think that
part of it,
matters.
yeah.
I think that matters. And the thing that I find so distressing about that is doctors act as though it's all about them. It's what we do, what we don't do. And I want to say, get over yourselves, because that's what it is.
It seems a lot of the arguments are being made without data. So with Oregon, there was an article in the New York Times about 2 months ago about this and focused on a doctor who chose to end his life. But there was this groundswell of expectation going back where they thought the poor were going to be wiped out because they'd be encouraged to take medicines and stuff like that, and none of it happened. So when you look at the number of people who have come through the Oregon system and chosen to end their life, it's a relatively small number of absolute people, right? And then there are some who didn't take it. But so there's all these filters. Where's the data that says a lot of people came in, they really wanted to get the drugs, but the system stopped them, and so were all these people turned back and you never get that data? Or did they never come in? Where is that information?
As I said, there was an early study of doctors who refused, and it was 80% of requests were refused, but we don't know why. We really don't know why, and it was probably a mixture of things, as I said.
Do we know the numbers associated with the 80%? If it was 10 people that came in.
80 requests were refused. I see. You mean what finally happened to them?
Did 100,000 Oregonians come in, and 80% of them were rejected? And,
I suspect that...
I suspect that's a pretty small population that came in to start with.
Yes, and that those who refused probably then got another doctor. Probably got another doctor. And, a lot of people who are critical of the Death with Dignity Act say, well, that leads to doctor shopping. Well, precisely. That's what you get to do.
Are there a last question?
Well, your question, you answered much of it. Do you have a sense of how many countries in Europe currently allow assisted?
I know of, there's just the Netherlands, Belgium, Luxembourg, and Switzerland. And if the Canadian decision withstands appeal, that will be all of Canada, because this decision applies to all of Canada. And as it now stands, it would not be limited to people with 6 months life expectancy, and it would include euthanasia. Now, I suspect that Parliament would rewrite things to limit it somewhat. But that would be our neighbor to the north.
Obviously, this is a serious question. Death is, after all, final, and so when we talk about it, we need to think very carefully. Do you think this is all part of a new thinking about death? as you say, antibiotics have come along, all kinds of treatments have come along. Death is not such a natural end of life anymore. And is this part of a whole new movement to think about the end of life, to think about the way we die?
I do think, Pat, that that's true, that people are starting to acknowledge that death is the end of life, that we all do it, and to not sweep it under the rug in a way that it used to be done, say, between World War II and Quinlan, when everybody was so excited about all the new technologies. And when I was in training, I hate to tell you how long ago that was, but it was in the 1960s. When I went to medical school, death was never mentioned except as a failure of medicine. Do this or else the patient will die. But the act of dying got no attention. And when I was out in training in the wards, there was no recognition of death except as a failure, or really of suffering. The treatment of suffering was very, very bad. You got small doses of morphine only every 4 hours. You couldn't get it any more often than that, and only if you could somehow get out of bed and run down a nurse who would give it to you. And then if you did that too often, then they decided you were becoming an addict and you got even less. So the handling of death was really very bad. Then there started to be more attention to it. Kubler-Ross published her book. The hospice movement came from England, and people began to realize that there are good ways to die and there are bad ways to die. And the initial change was in the treatment of pain. They began to set up pain treatment where you could give yourself the morphine as you needed, and they began to recognize the simple fact that people who take morphine for pain in hospitals do not run out in the street and try to get more as soon as they're discharged, that has nothing to do with addiction. And so very gradually we've begun to say, yes, it happens, and it can happen well or it can happen horribly, and let's make it good as it can be, as good as something like that can be.
Okay, thank you, Dr. Marcia Angell. Okay. You've been listening to a program of Cambridge Forum, recorded in October 2012, co-sponsored by the First Parish in Cambridge, the Lowell Institute, and the Friends of Cambridge Forum. For more information about this radio program entitled May Doctors Help You Die, featuring Dr. Marcia Angell, or about our ongoing radio series and Forum Network webcasts, visit us on the web at cambridgeforum.org. In Harvard Square, I'm Pat Zerke. Thanks for joining us.